Assalamualaikum. Thank you so much for the invitation. I'm very honored to the Malaysian Society of Nephrology and Dr. Esther for the kind introduction. So the topic for this afternoon is palliative renal support. Is it wrong to say no to dialysis? So, of course, it's not wrong. So I have a disclaimer here. 3 years ago, I was in King's College London, which I did a master's in palliative care by research. The reason why I wanted to do that was because of this young girl who is my niece. At age 9, about 5 years ago, I think, she said, no doctors will ever understand what Nene is going through. She is suffering. That is referring to my mother, who is actually on dialysis for the last 6 years. So the objective for today's talk is to try and make you understand the need for the comprehensive renal care or palliative care for our patients, make you also understand the approach of management option of no dialysis and the ability to translate all these things into clinical practice. So this is the outline of my talk. I will define what palliative care means in renal patients, the reality of end-stage kidney disease patients in Malaysia, and applying evidence into clinical practice, especially in shared decision-making, withdrawal of dialysis, non-dialysis therapy, and how do we move forwards and conclude at the end. And I'm sure you agree that nephrology patients are complex. They have life-threatening illness and their symptom burden is largely underestimated. And our renal patients definitely would benefit from incorporation of palliative care into their routine nephrology and general care. And over the past decade, there's lots of literature and research in nephrology per se, investigating the palliative care outcomes, and it has grown significantly. And the shift is now observed towards intervention examining palliative care, shared decision-making, non-dialysis pathway, which is also associated with patient, family, and clinical education and empowerment of these individuals. So many people would have thought or relate palliative care with cancers, but now with the transitions over the last few decades, palliative care has grown, and now they are managing non-cancer patients and those with advanced progressive chronic disease. This is in line with their actual definition, which is an approach which improves the quality of life of patients and their families facing life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and the treatment of pain and other problems, which is physical pain, psychosocial pain, spiritual and social pain. It's actually coined by Dame Cicely Saunders in 1964, and this concept, it has been the pillar of palliative care management and literature. So we know that the needs of palliative care, this is for Malaysia, is projected to really increase over the next 20, 30 years. And there is no way that just the palliative care physicians can address all the needs and issues in patients that need them. As shown here, the patients not only, this is the worldwide projection, palliative care is not only for cancer patients, but all other chronic diseases, and renal failure is obviously ranked top half of the patients that is in need of palliative care. A lot of us manage this group, which is preventing kidney disease. We want slow progression. This is what you do as a primary healthcare, as GPs and young doctors. This is what we really need to work on. For nephrologists per se, we know there's huge staggering numbers here. There's no way we could manage all kidney disease, which 276 million worldwide, and end-stage kidney disease, which is close to 10 million. And when they reach this stage, whether they could be given a care, whether they're dialyzed or not. And although patients, we traditionally know about hemodialysis, peritoneal dialysis, and of course, transplant is the treatment of choice here, there is also comprehensive conservative care, which is a non-dialysis pathway. So therefore, this is a recognized treatment, and it has been discussed quite extensively over the last couple of years in the nephrology community. Supportive care per se is actually based on palliative care principles. So, basically all our CKD patients will need some sort of supportive care. And we're looking at the quality of health, quality of life outcomes for this group of patients. In terms of conservative care, which is non-dialysis pathway, it is an alternative. It's not no treatment. It is an alternative to kidney replacement therapy, which is dialysis and transplant. We can offer comprehensive conservative care where it's either chosen by the patients and the family, or it's medically advised. So this is holistic. It's planned and person-centered, and this includes interventions to delay progression. That's for all. We have to have a shared decision-making. We have to have active symptom management, detailed communication, including aspects of advanced care planning, psychological, social, family support, and have cultural and spiritual domains incorporated within the care of the patients and families. And it does not include dialysis. In low-income countries, there are basically choice-restricted conservative care because obviously dialysis or transplant is not accessible. Let's go and look at what the reality is of patients in Malaysia. So we know that in Malaysia, or basically kidney disease in Malaysia, they present very late stage. This is a statistics or publication from Sabah, and I think they're doing a good job here. Most of the patients are known to medical services. It's not that they don't know, they know, but they really come in unprepared for dialysis. So this huge majority of patients do a lot poorer than the rest of the group. Bearing in mind, they have come in contact with a medical professional. They know presumably they've got renal failure, but they're just not prepared. This is my own data, which is taken from my local practice in Hospital Sultan Haji Ahmad Shah Temerloh, which incorporates Pahang Tengah. And I counsel the patients myself. 1 in 4 actually cannot decide on the modality of preference upon starting dialysis. So these are the patients who really, I don't know whether I think they're not just in denial, they just, because they don't feel it, they don't feel it, therefore they don't want to make a decision. I would say this is like ingrained in our population. It is a bit difficult for us to plan as nephrologists, obviously. You can see here PD is the first preferred modality in my practice, and we know our patients start dialysis very late, when the GFR is 6 to 7 mils per minute. And how do we address this? And so basically I would arguably say that patients in CKD stage 5, we should prepare them, not just talk about dialysis. Obviously, transplant is the only treatment. Dialysis is temporary, and PD is the preferred choice. That's how we go. And we can also potentially talk about non-dialysis conservative care for those who you think or they choose, or you think they cannot benefit from dialysis. And there is another group which just basically delay commencing and doesn't want to prepare for dialysis. I would say this is the 5th choice. Whatever it is, the palliative and supportive care should be given throughout the journey, because it's a journey of a CKD patient. And of course, there is also a withdrawal of dialysis on patients who don't do so well. So why do we have this kind of group? Well, this is our own publication, which we looked at the hemodialysis patients cross-sectional, and we asked back. And it's very interesting that patients actually took traditional and complementary medicine, and a majority of them, more than 70%, actually did not bother to tell us, doctors managing, about what they're taking. Why, we asked? Because 1, the doctors did not ask. 2, they think doctors won't approve, which is 1/3 of them, and a quarter of them say it's not necessary. This is very interesting, and obviously we need to do much better, because to engage our patients in their journey of towards end-stage kidney disease. So let's have a look at how do we apply evidence into clinical practice. So what evidence is there? This is the buzzword now, which is integrated end-stage kidney disease care. This is it's part of the universal health coverage, and conservative care or non-dialysis treatment is one of the options. So it is a known option for patients with end-stage kidney disease. And I have Don't need to remind you, our transplant rate is one of the lowest in the world. Therefore, our dialysis is temporary, is not the treatment. Therefore, I think we should go with this framework, which is suggested for low and middle income country. I would like to show you here that we should not just talk about HD. We should talk more about kidney transplant, obviously, and more peritoneal dialysis versus hemodialysis, because that is a lot more cost effective and a lot more beneficial. And large part of it, we have to talk about conservative care for those patients with kidney failure who cannot or do not wish to receive a kidney transplant. And this is the bulk of the work we should be focusing now. And obviously, nephrologists or palliative care physicians cannot address this, and this is where we need your help. And of course, this is what you already do, treatment and delay and prevent progression of kidney disease to kidney failure. I just want to tell you that I know our CKD CPG in Malaysia stated that EGFR is 30, less than 30 should be referred to nephrologists, but I would like to inform you that in my local setting, I believe less than 30 is too early for patients to see nephrologists. I brought it down to less than 20. Let's do this together. I think this is the buzzword now, shared decision making. What we do, we should be focused on the patients. We should be, it should be the pinnacle of the patient-centered care. But at the moment, it's very poorly integrated in discussion of dialysis and at the commencement of dialysis. And it's an approach to making decisions throughout the journey, whether you're starting dialysis or continuing dialysis or you're stopping dialysis. So this is the Renal Physician Association guideline, which came out, and these are the principles. First, you have to develop a relationship between yourself and the patient. You have to fully inform the patient the diagnosis, the prognosis, and all the options available, including non-dialysis therapy or withdrawal of therapy. Give patient an estimate overall prognosis. Institute advanced care planning. It's not legal in this country, but it would help if we could discuss and document in the notes. If appropriate, withhold initiating or withdraw ongoing dialysis for certain well-defined situations. Consider foregoing dialysis even for AKI, CKD, or end-stage who have poor prognosis, who or whom cannot be provided safely. Time-limited trial of dialysis. Establish a systematic approach for conflict resolution. Improve patient-centered outcomes. Offer palliative care services and intervention for all patients. It's not going to be easy for tertiary cares to deliver this. This is where we need all of your help. And use a systematic approach to communicate about diagnosis, prognosis, treatment options, and the goals of care. Just go back to the shared decision making. You have to share the decision between you and the patient, and in this context, in Malaysia, the families as well. The question about patient autonomy, which I'm going to address in the next slide. But, most of the times you don't share the decision with your patient. You sometimes don't agree with them. But I would suggest we potentially have to find a halfway where we could potentially share the decision sort of in between. This is when the discussion has to take place. You must remember, we are very focused on blood tests sometimes, and we forget that the things that patients want and need is different from what we want and we need. And this is very important. This is, I would urge, I put this out is because it's an article that was written by me and published last year. And when I looked at the preferences and experiences of Muslim patients and their families, I think I would say it is not just Muslim. Other families, other religion, other races as well. We have this concept of selflessness when the patients and the families is actually one unit. So I would like to show here in the discussion. Again, I would urge you to have a read of the whole article. I'm happy to share if you would request that through the email I'll give at the end. You have to understand the concept of selflessness, and it has been reported not just in Islam but in across different religions and families. It plays a huge role in clinical decision making. Hence, the question on patient autonomy had been raised. So therefore, a shared decision-making process is recommended, which will resolve potentially the conflicts between us, the healthcare professionals, and the patient and the families at the end of life. Whatever it is, our religion, Islam, recognizes and the limitations that we face in providing treatment and care, and acknowledges that if treatment is futile and does not lead to clinical improvements, withholding and withdrawing treatment is permissible. And in my practice, I have yet to have problems or conflicts with the patients' families. Of course, sometimes you don't get that decision in the one discussion. You probably need to do a serial discussions. But again, withholding and withdrawing takes longer than actually continuing dialysis. I can assure you that. What happens if you don't dialyze the patients? A lot of people actually say, oh, if you don't dialyze, you will die. That's not true, potentially. If you look at the CKD stage 5, the trajectory is different. Everybody has different trajectories. And this is very interesting. I would give you a case that I was managing and still managing, I have to say. She's a 62-year-old. She's a very independent lady, and she was actually caring for her late husband, who was on hemodialysis for 6 years. She was really traumatized and she hates hospitals. And her creatinine, when she came to us, was 1,800, and this was 1 year ago. And she's still surviving. She still does minimal daily activities of living. She cooks something she loves. She is managing, she hates tablets, so she doesn't take morphine at all. So she is much better with fentanyl patch. She doesn't need hospital admission. We provide home palliative care in our locality, and I'm very fortunate to have a wonderful colleague in palliative care department in the Institute Cancer Negara, which is next door. So we look at this, we offer the services, and I would urge, if you have this kind of patients, at the end of life, they become symptomatic and the families really at a loss on how to manage them. And if you're struggling, you could potentially find people or physician nearby to help to treat the disease, to treat the symptoms, not the disease, at the end of life, so that they are comfortable and they don't really be forced to change their decision at the last minute. Because if they want dialysis at the very last minute, they're already very ill and the prognosis is very, very poor and mortality is fairly high. But however, who do you say go for dialysis or who you don't offer dialysis? Remember, you could potentially offer conservative care for those who chose, like the first case I mentioned just now. But for those who medically unwell, medically not indicated, who are they? Who are you to decide? But of course, there are some sort of calculation. But I'm not a stickler for calculation. You could potentially use Charleston Comorbidity Index, but it is only an estimate, right? You have to discuss with the patients and the family, and you have to be able to give your own views and overall prognosis to these patients. Okay, the second scenario, she's a 77-year-old lady, also a very delightful lady. She knows she's got CKD. She knows she's been in stage 5 for many years. She chose not to attend any follow-up, and she's really, really not keen for dialysis therapy. She told the children that. And she's housebound, but she developed fever, shortness of breath, because she just couldn't tolerate it. She then requested to go to hospital, and I think duly they intubated her, and she had COVID-19 diagnosed, and she was in category 5, where her blood pressure was really low. She's in septicemic shock, and in this situation, I did not start dialysis. But again, the discussion has to be long, and fortunately, I had a son who did not stay with her, and he came from, I think, Terengganu, and I could meet him face to face. And I believe in this COVID era, discussion over phone or FaceTime, whatever it is not going to be easy for us to decide on this. What about withdrawal of dialysis? This is also a treatment of choice for patients who choose to be that way. Yeah, and it is actually the major cause of death of dialysis patient in the Western countries. And the decision to withdraw is not easy, it is complex, and it should be made jointly by the patient, the nephrologist, the relatives, the carers, and whatever other family practitioners and members of the caring people that cares for this patient, even in the hospital and in the community. So once withdraw, you basically last for between 7 to 9 days. However, there are patients who just started dialysis. They could potentially last longer than 8 days. I had a patient who lasted for 3 months. So this is another scenario. 70-year-old gentleman previously refused dialysis. Same old story. Late start dialysis. Father of a healthcare professional. He just basically no vascular access and refused peritoneal dialysis, and he had to be on IJC. And obviously, he developed septicemic shock after 2 months of starting hemodialysis, and came to hospital, arrested, and had to be CPR for 8 minutes and had no GCS recovery. So obviously, in this kind of patient, we withdrew dialysis. So, end of life withdrawal, palliative care is actually an important management of our patients. And this is a study which showed that acute medical complication was the most common reason for for withdrawal of hemodialysis for somebody who's already on dialysis. Withdrawal decisions, some of them here made by patients, majority, and here 1/3 made by family members. And the reason for withdrawal was acute medical complications and, of course, frailty in 1 in 5 patients. So this, again, a scenario. I'm just going to be one slide on time-limited trial dialysis. This is a very well lady who developed arguably acute kidney injury, and CT scan showed extensive cancer in her retroperitoneum, pelvis, which she had obstructed kidney disease, and even with nephrostomy, it did not reverse. And knowing very well her prognosis is very poor, what would you do? She's otherwise well. The only thing is she needed dialysis. So I wasn't happy to obviously forego life just because we did not want to initiate dialysis. So therefore, I gave her a trial of dialysis. I personally call it palliative care dialysis, palliative dialysis, which is time trial. But obviously, we know the prognosis is very poor. She died in her sleep about 3 months after commencing dialysis. She was only on catheter. We don't do a fistula because obviously her prognosis is very poor. This is a scenario which I encountered recently. She was 76. She is very clear in opting for non-dialysis therapy. She was followed up regularly, and all these were documented and discussed fairly well. She has a small book. She came to Klang Valley with the MCO. She couldn't return home, and she became dysnic, and the children brought to a GP, and GP, looked at the creatinine, like, it was 1,700, and she just okay, you have to go to hospital. She was clearly refusing this. She was clearly refusing hospital admission. When I did a home visit about 2 days after, and we discussed, and she kind of agreed for blood transfusion. The hemoglobin was 4, but on the day that she was supposed to come in, she refused. And she was very clear. I let the family, she was very clear not wanting dialysis. I let the family took a video of me discussing with her, because I can see the children who did not follow her follow-ups were not very clear about their decision and why and how and all the rest of it. So I felt the children that was present that day were okay, but not knowing when the actual time came, the son-in-law, which is one of the youngest daughter's husband, was panicking. Arguably, she was staying in his house, and she became in GCS. She became drowsy. GCS was sick, and he panicked despite us trying to, counsel them. And he called for ambulance, and just in time for the son from Johor Bahru to arrive, and decided, look, she doesn't want. Let's take her home, and which they did, and she died about within an hour of arriving back to the daughter's home. I felt a bit bad because she was the one who told me she hates needles, and thankfully, knowing that she had an ambulance call, I alerted our emergency department, saying that we shouldn't be intubating her. We should just give her comfort care. How do we move forward from here? And I'm the current chairman for Integrative Renal Palliative Care Services in Malaysia. And I hope at the end of this strategic plan duration, we could have some sort of clustering or some sort of working together with the primary care, be it in the government, be it in the KK government, or even in the community, in the private. I would hope to develop this in your help, and we could potentially work together in developing this in the community. But before that, I need to make sure that we have a very solid foundation, and we have a very good way of that discussing pre-dialysis education and giving the empowerment for patients and families to understand what their options are, and what how best to make the best management that suits them, basically. And this is when a pre-dialysis education program is going to be incorporated into our current My Buah Pinggang website that we have. This is our website. I hope you could potentially, when you see your patients, you could potentially ask them to go to this website. Within this year, we'll develop a very comprehensive pre-dialysis education program so that patients and families can choose which modalities suits them, and we can go and work together with them that way. And this is a national palliative care policy and strategic plan, and there are plans to actually move the care jointly into the community, and to establish a dedicated domiciliary palliative care program and team. And I can assure you, this is so fulfilling. I did mention earlier on, I've been lucky that I worked in Putrajaya, where our colleagues in a National Cancer Institute has a wonderful palliative care team, wonderful nurses who goes out to the community. I go out to the community. I bring my junior doctors along as well, and we try to get them to stay out of hospital. And it's not a safe place at the moment. And as you know, hospitals, we can't even have families. And I think family, as I've already proven, is a very important component of our patients, and I'm sure we all agree to that. So to conclude, ladies and gentlemen, I hope I've impressed upon you that non-dialysis or conservative care and withdrawal are options for end-stage kidney disease patients, and dialysis should not and cannot be provided if it is unsafe to deliver and the treatment is futile. And we as healthcare professionals can make that decision. And whatever it is, it has to be shared as well with the patients and the families. And there is also a need to work together. I've already alluded upon you that we don't have hands, legs to do everything. And this is where we really need you. And I would welcome anyone to come on board. Even from now on, we can devise something together that we can deliver the best care, the best comprehensive care that suits your end-stage kidney disease patients in the community. And please, we are unique. We don't have to follow the guidelines of international guidelines and things like that. When I was in the UK studying palliative care, they actually look at us in Malaysia. They really want to learn from us. But what we need to do, we need to understand. We need to have our research and change our focus and prioritize this in the near future. We can showcase to the world what our population needs and what our limitations are, and how best we do to address these issues. I'm sure we have done our utmost best to do this. And this is the last slide. And again, thank you for listening. I would also like to thank my nephrology colleagues who were at the heart of the Facebook page that we have. Some may know quite well. With that, I thank you for listening, and I'm happy to answer any questions later in Q&A, and you are welcome to email me, and I'm really welcome for those who would like to work together hand in hand with me to give comprehensive renal care to the patients in the community. Thank you very much. Assalamualaikum.